because the center of gravity is always going to go forward. You can't go backwards. We all know that there's no backwards.
Good morning. Happy Wednesday. I have Neuro Coffee in hand, and it is perfect. Okay. Well, happy Wednesday. It's Wednesday, so that means that tomorrow's Thursday, which means 6 a.m. tomorrow morning, the Coffee and Coaches Conference call, as usual, as we have done for over the last year. So if you haven't joined us, please join us. Great group of people, great questions, solving problems, always fun. Speaking of the Coffee and Coaches Conference call, today's Q&A is with Cameron. So Cameron's a frequenter of the Coffee and Coaches Conference call. And we dug into some pelvic orientation stuff. So this is actually some really, really good foundational information in regards to the anti-orientation representation, how the superficial strategies will influence this. We talked a little bit about strategy in a specific case situation, which moved us into a little bit talking about this later representation of the propulsive foot. So again, really, really good foundational information. I think it's going to help a lot of people. If you would like to participate in a 15-minute consultation, please go to askbillhartman@gmail.com, askbillhartman@gmail.com, put 15-minute consultation in the subject line so I don't delete it, and we'll arrange that at our mutual convenience. I hope you have an outstanding Wednesday. We'll see you tomorrow morning, 6 a.m., Coffee and Coaches Conference call. Have a great day.
Okay, we are being recorded. The clock has started. Cameron, fire away.
Okay. So, sorry, I just have to put the volume up a little higher. I guess I had kind of a two-part question. I suppose the first part's kind of vague, and then I'll kind of give you for an instance. So I guess I was kind of wondering what sort of the anterior sort of pelvic orientation strategy and kind of the relationship with that is with like the posterior lower, sort of as people get closer to an end game strategy. Is the anterior orientation just like an earlier sort of like earlier in the sequence of a compression strategy that someone will use, let's say in like a narrow ISA?
Yeah. So, okay. So when you think about how the superficial stuff is laid on, what we're doing is we're creating changes in the ability to produce the downward force. All right. So anything that you lay on that's superficially driven is going to be an exhalation strategy. So it's going to squeeze you harder. It's going to create more compression, right? And it's typically going to be associated with trying to produce more force downward. Okay, so it's an IR representation. I happen to have my pelvis sitting right here.
Yeah. Nice. Okay,
so when I take this, so we sort of have this little cutoff line here, right through the ischium there at the top of the acetabulum. So that's why I sort of make my cutoff in discussion purposes. So I have musculature that's right here that's going to create this posterior compression and drive. When we're talking about the sacrum, it's going to push the sacrum that way, right? And we're going to see the same thing in the thorax getting pushed forward. And so if it's above the axis of rotation and I push this forward, it does that. Okay. So it pushes down. This is down, right? So anytime I see something that goes that way, so my anti-orientation is me trying to push that internal rotation downward. Okay. Does that help you?
Yeah. So that would be more of a like associated with the the compression strategy would be above the level of the greater trochanter. I guess would often end up in kind of the space orientation of more of an anterior sort of pelvis orientation.
You don't really have a choice because when you think about the anterior musculature, so the anterior musculature is here, right? Okay. So if I start pushing here and this goes forward and then I push back here, look, it's kind of like this perfect storm, right? To create this downward force and then the orientation. I mean, like I said, you're just going to see the same thing happening in the thorax.
Okay, yeah, that clears it up.
Okay, let's talk about posterior lower though. Can we do that?
Yeah.
Okay, because you mentioned it. All right. All right. So here's what's going to happen. So we got to go through space time, right? So I start pushing here. I'm pushing this forward, right? This pushes back, and then I keep going forward, right? My center of gravity is going to go forward under these circumstances. So eventually, I'm going to see this, where the pelvis is moving through space in that direction over the femur. So I'm going to fix the femur to the ground through the foot as a representation, right? So now I got this musculature down here. The farther forward that I go, this is going to be able to pick up concentric orientation.
Right.
Okay. So that and then that creates compression in the posterior lower aspect of it. That's how you start to pick that up. So if we were looking at, say, a wide ISA representation, right? Because typically under those circumstances, I'm going to have a nutated sacrum, which is going to give me eccentric orientation of that posterior lower aspect. But if I keep pushing things forward and forward and forward, again, I start to pick up concentric orientation here, and then I start to bend this sacrum up underneath. So that's one of my favorite representations to understand how you pick up this stuff, right? Because all it is I'm moving the two ends of a muscle, right? Closer and closer together. So it picks up concentric orientation. So that's a compressive strategy. So you slowly increase the amount of compression that you can apply in that area, because the center of gravity is always going to go forward. You can't go backwards. We all know that there's no backwards.
Right.
Just doesn't happen. And so you're always going to go in that anterior direction.
So I guess staying on that topic then, let's say if, like, for an instance type situation, or have someone maybe kind of presents where they're on that sort of right oblique angle, and then they've been pushed forward far enough at that point. So now they've got a loss of, early hip flexion, ER, IR, much greater on, like, let's say the right side than the left side.
In regards to which?
The hip.
Which, when you say greater, you were mentioning ranges of motion. So
sorry, ranges of motion. So like both hip, ER and IR.
Yeah. So if they start, okay, I understand now. Yeah. If you got somebody that started on a right oblique that loses hip IR, they're getting pushed way forward.
Okay.
Way forward.
So, and that's it. I guess I've been and maybe I'm getting too deep into it, but how much do I kind of need to pay attention to, like, the internal precision forces of?
Well, they're there. That's what's driving the show, right? And that's why all those strategies exist in the first place, is to control the forces.
Yeah.
Right.
So if I'm trying to, like, if I'm trying to give someone some, like, early, let's say, like, early hip flexion on that right side.
On the right side? Okay.
On the right side.
Okay, let me help you.
Yeah.
All right. What direction did they move first?
They moved to the right first.
They moved on the oblique to the right.
On the oblique, the up and over for that relative.
And then what direction did they go? To lose the early hip flexion, straight leg raise, and internal rotation. What did they lose? What direction did they go then?
Forward.
Okay. So if you were going to reverse engineer this whole process, which direction would you move them first?
Backward.
Yeah. So straight back and then back on the oblique. There you go.
Okay.
This is because everybody's going to end up in the same place.
Yeah.
Generally speaking. Right? Because we're all dealing with the same forces.
Right.
So we're all going to try to end up in the same place. It's just like, how did you get there? So we have different starting conditions. So if we look at my wide ISA archetype, and we look at my narrow ISA archetype, those are just different starting conditions. Forces being the same, they're just going to behave a little bit differently. But ultimately, because it's the same force, they're going to manage it very similarly as they start to lose capabilities, right? Yeah. So they all start with different strategies, but they're going to end with the same one, because everything gets narrower and narrower and narrower as far as, like, what's available to you. So if I start with this big of a space to move in, right? And then I start to battle whatever it is, internally and externally from a force standpoint, and slowly squeeze everything in. Now my movement capabilities are here, right? And that's going to happen to both archetypes. But because the starting conditions are different, things drop off at a little bit different sequence. But ultimately, at end game, they're going to measure very similarly.
And so then say if we went down to the foot, because that was kind of where I was sort of trying to piece together that what we were just talking about to what the foot representation would be. So in that case, would it look like that? So we get closer to that sort of end game situation where someone's pushed far enough forward that their foot presentation would probably look a little bit more like either the high arch type person or the foot turned out. Because and that's why you would say you've got to get them to early propulsion first.
Right, because so it's an ER representation. So remember, a late propulsive foot is the external rotation, right?
Tibia and stuff, yeah.
Yes, sir. Yes, sir.
Yeah.
Right, but because the center of gravity is not far enough forward, the heel is still on the ground, so it pulls the arch back up, and then I bring the toes back underneath. So the muscles that would typically lift the heel in a normal late propulsive representation can't lift the heel because center of gravity's not far enough forward yet, and so it reverses gears, and then it's dead guy anatomy 101. What do these muscles do based on their name? It's like, well, they're toe bender muscles, and so I got short toe extensors on top. I got long toe flexors on the bottom, and I get this clawed representation of the toes. That's why you see that, is because that's somebody that's trying to get up and over the front of their foot, and they can't do it because their center of gravity is too far back. So it just grabs and pulls.
So that would be the airplane wing sort of situation you're talking about, where like got the high pressure underneath. That's the concentric overcoming in that situation. Okay.
Yes.
All right, perfect. This is clearing a bunch of little stuff up for me.
Good. You got 5 minutes.
So, 5 minutes?
5 minutes.
Oh, perfect. So then I guess kind of there's one exercise that you had put up quite a while ago, and then I saw I was following Mike Campernini, and he had executed this exercise where the one, it was more for like a wide SA individual, and they're trying to regain hip internal rotation with the bands around the knees, and you went towards the deep squat.
Deep squat.
So I guess for my interpretation, it was like you're going out to try to force IR to try to create that concentric. Yeah.
Okay. So you're not pushing out.
So you're still not. So even in that wide sitting, it's still not a push out. It's still
you're not pushing out.
Okay.
You're trying to reduce the. Okay. So the muscles above the trochanter, as the pelvis becomes anteriorly oriented, they become internal rotator muscles, right?
Right.
They change their direction of pull, right? So for me to sit down into a deep squat, I'm trying to capture an ER representation, early propulsive representation of that pelvis. So if that musculature is concentrically oriented, the chances of me capturing an early representation of the pelvis in the bottom of a deep squat are slim to none. So what I'm doing is I'm fixing the femur with the force of external rotation against the band, but I don't want to push it apart, because if I push it apart, all I'm doing is creating the posterior lower compression, and I'm orienting the femurs into ER. I want to capture relative motions in the pelvis. So what I have is a stimulus, that band stimulus creates the ER moment that makes the musculature above the trochanter eccentrically orient as I descend into the deep squat. Then I superimpose the inhalation on top of that, and I get this nice little early representation at the bottom of the deep squat. That's what that's for. Because if you watch the sequence, you watch the sequencing, so you start in a late propulsive representation at the top of the squat. You've got the foot elevated on a platform, okay, with toes in line with the forefoot. Okay, so it's not the late representation. Just elevating the heels doesn't do it. You need the platform to do this. Okay. Yeah. Right. And so as I descend, you descend it with an exhale till you get through the sticking point where you would be biased more towards that internal rotation. Well, that's where the pelvis is going to start to pick up that IR representation. So the musculature above the trochanter is going to be more IR biased, right? I have the band on there that's going to reduce the ability of those muscles to maintain their IR bias. And then I sit down below that level where I would typically recapture early representation. And I breathe in, sacrum can counternutate. I have ilia that can ER under those circumstances, and I capture that early representation of propulsion at the bottom of the squat.
And would kind of the like an analogy to that exercise for the upper extremity be that like dorsal rostral band pulled apart?
Yes.
Okay.
Yes.
All right.
Yes.
How much time do I have?
1 minute and 31 seconds.
So let's say if someone, all right, I think I can do this quick. So let's say spend a session, they've regained some semblance, even if it's of internal rotation at that point. Let's say for like our younger population, or it doesn't have to be younger, but just anyone that's more of our that wants to be active in that case. So if I want to kind of use that range, would that be now, let's say if I want to start to use like a change in tempo, would that be more of like, so now I want to be able to drop quick and have that heavy exhale to grab that concentric orientation and use what they just got?
Yeah, you can do that. You can do that. And you're also influencing connective tissue behavior into the overcoming action as well. So you're getting a lot of stiffness, right? And so, yes, you can. So we'll start to do that too. You can actually, I do that with my patients all the time. They don't recognize it, of course, but yeah, you can definitely do that.
Okay.
Yeah. There's nothing wrong. Like the forces matter. The forces matter. Like going quickly or going slowly does matter. If I'm trying to create an expansive strategy, I will tend to slow the tempo down. If I'm trying to create more of a compressive strategy, overcoming action, that's a higher rate of load for sure.
Yeah. Yeah. I guess that's the part where the patient population, right? I don't get, either I don't recognize it, or I'm just, I don't have the clientele that I'm usually just working on expansion all the time for pain relief in that case.
This is where your safe to fail experiments come into play, young man. This is how you learn. Right. As long as you understand the representations, experiment, and then look at the outcomes and let that lead you. Okay.
Okay.
All right, man.
Thanks,
Gotta
Bill.
go. Good to see you.
Yeah. Talk to you later.